Hi, I'm Nikki McClaskey, and the disease I'll be talking about today is called transposition of the great vein. It's also known as transposition of the great artery, and typically you use abbreviations TGV or TGA, so I'll use that all synonymously throughout this presentation. Transposition of the great vein is a cyanotic heart disease that accounts for 5 to 7% of all congenital heart diseases. Approximately 1,900 babies are born with TGA per year. It can be detected during prenatal ultrasound, which I will elaborate on more based on the article Prenatal Diagnosis of TGA by the Canadian Journal of Cardiology. In TGA, the pulmonary artery and the aorta are switched in position, which causes a left to right shunt. So as you know, normal blood flow through the heart, the blood goes into the right side of the heart through the pulmonary artery, and then it picks up oxygen in the lungs, and then it goes back through the left side of the heart out to the body. In this case, when the aorta and the pulmonary artery are switched, it skips the step of going to the lungs. So the deoxygenated blood is distributed through the body, which is why one of the first symptoms of TGA is cyanosis. Tachypnea and clubbing of fingers and toes are the other most common clinical manifestations that are associated with this disease. Chest x-rays can be done and the heart will show an egg shape rather than being in its normal position, but an echocardiogram is definitely the better diagnostic tool because it shows more. Because of the hypoxia, O2 therapy is the first treatment that's done for babies who come out with TGV. They use prostaglandin E1 therapy. That medication can be given to babies, which helps maintain an open ductus arteriosus. A balloon atrial septostomy does the same thing. It aids in leaving that ductus arteriosus open. Ultimately, surgical correction needs to be done where they switch the aorta and the pulmonary artery into their proper positions. Improvement after surgery is usually lifelong and patients have minimal issues following them, but without surgery, the life expectancy is very, very short. It's only several months. As I mentioned earlier, TGV can be detected by ultrasound prenatally. Because the placenta provides adequate oxygenation for the baby, it doesn't pose a problem in utero, but once the baby is outside of the uterus, the deoxygenated blood causes cyanosis, hypoxia, and respiratory acidosis as well. Studies have shown that babies who have been diagnosed with transposition of the great vein prenatally only have a mortality rate of 1.4%. where babies who are diagnosed postnatally have an increased mortality rate of 12%. So you can see that it's very important to diagnose it prenatally, but it's incredibly difficult. It can be helpful, but again, it's very, very hard to detect. The ultrasound technicians typically use a 3D or 4D study for clear or more precise imaging. The 4 chambers of the heart are very easy to see on the ultrasound, but sometimes it's really hard for the technicians or even the radiologists to differentiate between the pulmonary artery and the aorta, which can make it incredibly hard to diagnose. So a lot of times, even if they check for it, it goes undiagnosed. Regardless, prenatal findings of TGV allow proper preparation for immediate oxygen therapy for the hypoxia, prostaglandin E1 therapy, and the BAS to maintain a patent ductus arteriosus, and it also allows for neonatal cardiologists to be prepared to perform the surgical switch as soon as possible.